Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Welcome back to Behind the Knife. I'm Dr. Maddie Cloonan, a general surgery resident at the University of Nebraska Medical Center. I'm joined today by three phenomenal members of our transplant team, Dr. Evelyn Waugh.
I'm Evelyn. I'm the Senior Transplant Fellow at UNMC.
Dr. Jackie Dauch.
Hi, I'm one of the abdominal transplant surgeons at UNMC.
And Dr. Alex Maskin.
I'm the kidney and pancreas transplant surgeon at UNMC, and I'm also a co-medical director of our local organ procurement organization.
We will discuss abdominal organ procurement in both brain-dead and donation after circulatory death donors, covering the warm and cold phases, donor hospital logistics, and considerations for pancreas, small bowel, and multivisceral transplants, all while emphasizing both the technical and non-technical aspects of procurement surgery. This is such an important operation for both donors and recipients, but it can be surprisingly hard to find detailed, practical teaching about it. We want to open up that black box. Before we dive into the technique, can we zoom out for a second? What actually has to be in place before we even go to the OR for an abdominal recovery?
Yeah, thanks, Maddie. Happy to talk about kind of the beginnings of organ procurement, which mainly involves organ procurement organization before the surgeons actually step in. So there are a few things that must be in place before a donor procurement can happen, and they don't involve transplant teams or surgeons. So first, there's a medical determination that ongoing life-sustaining therapy is inappropriate. So for patients who are brain dead, the ICU or neurology team must complete or document a formal brain death evaluation. Once a patient is declared brain dead, the local organ procurement organization takes over the care of the donor until the organ procurement. For DCD donors, the ICU team must complete the withdrawal care plan and is solely responsible for monitoring and managing the patient until the official declaration of death. So once a donor is identified by the hospital, they are legally obligated to call the local procurement organization to evaluate. Local procurement organization evaluate the patient. We have a team of family support coordinators who go into the hospital to obtain authorization. So patients can either be registered on their driver's license or unregistered. When the OPO comes in, they obtain the authorization for donation. So like I said, that may be first person authorization to the donor registry, or they can obtain consent from the family. And third is donor suitability and acceptance. So the OPO confirms which organs are being potentially allocated and compiles everything into a packet, which includes the donor history authorization, documentation of the brain death or DCD declaration plan, lab data, and lists of organs to be recovered. Organ acceptance is done through the UNOS match run, which is the national matching system. And then the OPO calls the separate organ acceptance teams and coordinates the donor procurement.
It's really interesting to hear how much goes on before the operation even takes place. So let's set the scene. You're a second-year resident, and it's your first day on your transplant rotation. You receive a text from your fellow, "Hey, leaving for a donor at 10 p.m. You grab your loops and frantically try to review for the case. When you arrive to the donor hospital, there are about 30 people in the operating room, and you're trying to make sense of everything. Dr. Maskin, can you walk us through who's in the operating room for a donor recovery?
Sure. When you walk into a donor arc, there are many people doing different things, but the roles are actually very clear. A donor case generally involves three separate teams with distinct responsibilities. The patient is initially in the ICU. The ICU team manages the donor from the time of care begins until death is formally declared. Like we said before, once brain death is declared, the OPO takes over. This is different from DCD donors in which the hospital medical team cares for the donor until the procurement. They are also the ones who declare death in the OR. And here's the key point. The transplant teams, e.g. the teams coming in to recover the organs, are not legally allowed to declare death, ever, not in brain dead donors or in DCD. That separation is intentional, both ethically and legally. So once the donor has been stabilized and deemed eligible for donation, the organ procurement process and the OPO becomes a central coordinator. And their role is broad and highly regulated. They're responsible for confirming the authorization of donation, ensuring the documentation, reviewing medical history and imaging, coordinating the organ offers and matching, and arranging infectious disease testing and serologies. Once all this is done, they prepare the OR, they plan for the organ storage with preservation solution and ice, notifying and coordinating with all the different recovery teams, especially in a multi-organ donor, and briefing the hospital staff at which the donor resides about what will also happen. So the donor or hospital staff, in conjunction with some of the OPO staff, including the circulating nurse, scrub techs, anesthesia, support the actual procurement. They prep and drape the donor. They manage the donor's hemodynamics during brain-dead donor cases, handle instrumentation, help gather equipment. At smaller hospitals, they sometimes have limited experience with procurement, so the OPO and recovery teams often help guide the workflow.
So there really is some method to the madness. Before we really dive into cases, Dr. Dauch, can you take listeners through the donor categories and why warm ischemia underpins everything we do?
Sure, absolutely. Honestly, this is one of the most important foundations for understanding how these operations work. When we talk about deceased donors, we're really talking about two major categories that differ in both physiology and workflow. First is donation after brain death. In brain-dead donors, donor hemodynamics are supported until the moment of procurement. Because circulation is intact, there's no warm ischemia until we physically apply the aortic cross-clamp in the OR. So for brain-dead donors, warm ischemia is short and predictable. The next type is donation after cardiac death. DCD donors follow a very different sequence, and this is where warm ischemia becomes critically important. In a DCD donor, life-sustaining therapy is withdrawn. After withdrawal, the donor's vitals are monitored continuously. If the donor reaches circulatory arrest and is declared dead by the ICU team, then we begin the recovery process, and only then. A mandatory no-touch period begins, which lasts 5 minutes. After the no-touch period, the ICU practitioner listens again and confirms time of death. Only after that, the team's allowed to begin the procurement, so you can already see that warm ischemia accumulates throughout this entire sequence. Warm ischemia out. It is the time the organs spend at body temperature without adequate perfusion. Total warm ischemic time. This is the broadest measure. It starts at withdrawal of life-sustaining therapy and ends at aortic flush or cross-clamp. We also consider functional warm ischemic time. Functional warm ischemic time starts at the first sign of inadequate perfusion, which is accepted to be the first systolic blood pressure less than 50 or first oxygen saturation less than 70. Functional warm ischemia ends when the organ receives cold preservation solution at flush or aortic cross-clamping during standard rapid recovery. Warm ischemic time is associated with early allograft dysfunction, delayed graft function in kidneys, biliary complication in livers, and ultimately graft survival. So everything we do, from the pre-withdrawal huddle to minimizing delays to coordinating the teams, is about limiting ischemic time to maximize organ function and utilization.
Great, let's move into cases. Dr. Waugh, you are told you'll be performing a kidney and liver recovery on a 22-year-old male who is in an MBC and was declared brain dead by the ICU team after a devastating neurologic injury. Before you walk into the OR, how do you prepare surgically?
So you may receive a lot of information about the donors in the donor summary, which you would have access to before even leaving on the procurement. But sometimes these histories are incomplete or inaccurate, as oftentimes this information comes from the patient's family members. What I really care about is the CT and the past surgical history. If I could review only one thing about the donor, it would be the CT scan. I always look at the vasculature to see if there's any arterial variants, like an aberrant right or an aberrant left. I look to see if there's any aortic plaque, and I use the CT to plan where I'm dividing the aorta. I look to see where the SMA comes off versus the renal arteries, and this will help me plan how much room I have to divide the aorta and how much angle I need to cut at. I also look for any evidence of previous surgery, such as an abdominal mesh or previous sternotomy with wires. Have they had a Roux-en-Y, gastric bypass, or cholecystectomy? Really looking for anything that could mean scar tissue or potentially previous injury to the liver's blood supply.
So you review the CT. It's a trauma protocol, chest, abdomen, pelvis, and the contrast of the timing is not perfect. You can't clearly delineate anatomy, but the SMA appears robust. So you're prepping for a possible accessory or replaced right. There's no evidence of previous surgery, and this aligns with the OPO's report. What do you do when you arrive to the donor hospital?
First of all, I make sure to introduce myself to the entire team in the OR and the OPO team members. I do an armband check to verify the donor ID with the OPO personnel. I do the OPO paperwork, which means confirming the identity, the ABO, the authorization for donation, and that the documentation of death is complete. Next, I go over the back table. I want to make sure they have a functioning sternal saw with the saw blade facing in my preferred direction, and that they actually test it in front of me. I also look at the finishetto, as occasionally this is assembled upside down. For a brain-dead donor, we need 4 penetrating towel clamps, Mayo and Metz scissors, a Babcock, some hemostats, DeBakey's, a right angle, and a non-penetrating towel clamp, as well as a blue towel. I also look at what they have available for an aortic cross clamp. I'll ask for some basic sutures and ties. I then ask to see what they have for an aortic cannula. Typically pick between a 20 and 24 French for this, depending on the donor size. And I also want an IMV cannula for a brain dead donor, which is often an 8 to 10 French pediatric Foley. I'll also need another 8 French cannula cut in half and a bulbed syringe to flush the gallbladder. Finally, we need a bovie and ideally 4 suctions. If I don't bring a headlight, then I'll ask for one, and I always double check that they have ice prepared.
Great. I think this is really important because these scrub techs are not only are they going to be assisting you, but they're also obviously going to be assisting the chest teams. And so it's nice to go over your most important instruments with them. Dr. Dauch, your resident asked to review the operation prior. Can you walk us through the high-level steps that you run through to someone who has never seen this operation?
Yeah. Here at UNMC, we teach our fellows to make a cruciate incision. The first thing we do is take down the falciform and biopsy our liver to send that off for pathology. And then we perform a Kettelbrasch and Coker, basically to be able to see our left renal vein, right renal vein in the SMA. Following that, we tend to take down Luttrell's fascia and swaddle our small bowel and right colon so that we can cannulate our IMD for a portal flush. And then we get around our aorta and dissect out our common bile duct and flush our gallbladder and the common bile duct itself, and then dissect out our GDAs. After that, we will mobilize our liver if we have enough time, depending on what other procurement surgeons are in the room. And then we'll proceed by getting superative celiac control. And then depending if there's a heart team or not, one of the teams will perform the sternotomy. At this point, we ask our anesthesia colleagues to give the heparin, and then we'll proceed by cannulating our aorta and flushing, as well as venting our heart, and then performing cross clamp. At that point, what we'll do is take our liver out and then move on to get our kidneys mobilized. And then last but not least, we'll take out our iliac vessels as well, just in case we need them transplant side of the operation.
Great. Let's go through a little more granular detail. Can you make sure to point out where residents can help the most?
Yeah, absolutely. So I start by making an incision from the sternal notch all the way down to the pubis and enter the abdominal cavity using cautery. We'll then lift the umbilicus with 2 penetrating towel clamps on either side and create our cruciate incision. The assistant can help by lifting both sides with the piercing towel clamps as the surgeon divides the right abdominal wall. And then I'll have my hand behind the abdominal wall, keeping the small bowel out of the way. The left side is similarly opened with the assistant holding up on the abdominal wall. And once our cruciate incision is complete, we'll put the clamps out laterally to provide the maximal exposure. Next, I'll take down the falciform ligament all the way to the level of the hepatic veins / upper IVC by retracting the liver downwards with my left hand. At this point, I'll get a biopsy and inspect the liver, as well as ask our donor coordinator to take some photos and send back to the accepting surgeon. At this point, I'll also take down the left triangular ligament by placing my right hand on either side of the left lobe, pulling down towards the feet, and then using the bovie to divide the ligament with my left hand.
Dr. Dauch, can you walk us through what we mean when we say Kettelbrasch and extended Coker? What actually happens during these maneuvers, and why do we care?
Absolutely. This is a core part of abdominal organ recovery, and it's much easier to understand if you visualize it as a single continuous right-sided visceral rotation. It's based on the anatomy of the white line of Polt, the lateral peritoneal reflection where the right colon and small bowel mesentery fuse to the retroperitoneum. It allows you to rotate the entire right colon, duodenum, and small bowel mesentery immediately and expose the entire retroperitoneum, including the IVC, aorta, all the way down to the bifurcation, SMA and IMA, left renal vein and left adrenal vein, both ureters, head of the pancreas, and the duodenum. You can break it down into a couple of steps. First, right colon mobilization. The assistant lifts the ascending colon medially. You incise the lateral peritoneal reflection from the right iliac crest to the hepatic flexure and then the hepatoduodenal ligament. Identifying the ureter early and protecting it is essential in this part of the case. The colon rolls toward the midline. This exposes the retroperitoneum and lets you approach the duodenum and pancreas head without tension. Next, the extended Coker maneuver. You incise the peritoneum along the right border of the duodenum, open the inferior avascular border of the foramen of Winslow. Continue freeing tissue between the posterior pancreas and duodenum and the IVC, mobilizing the duodenum and pancreas all the way to the SMA and aorta. You know it is complete when you have mobilized the entire duodenum and the pancreas head is lifted off of the IVC and aorta, exposing all major vessels, and you can actually see the left renal vein at that point. Lastly, it is the small bowel mobilization. Placing the duodenum colon back to the right briefly, then moving the entire small bowel to the right side of the abdomen, incising the peritoneum from the ligament of Treitz to the right iliac artery, freeing the small bowel mesentery off the retroperitoneum until it is completely mobile. The end point is when the small bowel and colon can be lifted out of the abdomen and placed on the chest.
Next, at this point, I find the SMA, so I'll swaddle the small bowel and colon in a blue towel and secure it with a clamp, then have the assistant retract the bowel cephalad or into the chest. I'll palpate at the root of the mesentery, just superior to the left renal vein, and use a Bovie and DeBakey to dissect through sometimes dense perineural tissue encasing the artery to expose the posterior surface of the vessel. After this, I identify the IMV and cannulate it for the portal flush. We can find the IMV just left of the root of the mesentery, and I'll dissect out a couple centimeters, placing one tie proximal, wrapped doubly around the vein, but not tied down, and then one distal, which I tie down. I'll then partially transect the vein and insert an 8 French beveled cannula. While I'm doing this, I'll have the assistant gently retracting the lower tie towards the feet while I insert the cannula and tie it in place. Here, we will start a drip of LR just to keep this cannula open. Occasionally, this cannula will get inadvertently displaced by the assistant, so I always remind them to be mindful of it at this point.
After that, we move on to the aortic dissection, just to make sure it is completely done in case the donor becomes unstable throughout the procurement operation. Typically, what we do is dissect around the aorta with a Bovie because there's a lot of lymphatic tissue in the area that can bleed pretty easily. What we do once we're down at the bottom of the aorta is take a right angle and maneuver underneath the aorta just on top of the spine, taking care to look for any lumbar vessels that are coming off in that space. When we get around the aorta, we're typically about 2 centimeters above the bifurcation. When you're looking down at the aorta on the patient's left side of their body, the INA will kind of come into view there. So just want to make sure that you stay away from it and don't cause it to bleed. Although if that happens, we usually just kind of clip it in that space. Once we get our right angle around the aorta completely, we put 2 number 2 silks. These are used later when we cannulate to keep our cannula in place. Of note, you should always just keep an eye on where the ureters are in this location. Once we're around the aorta, we move on to dissecting out our portal structures. First, we'll come across our common bile duct. I'm dissecting this out and flushing our gallbladder and our common bile duct. Typically, what we do is just snip into the common bile duct and place a little cannula in it to flush it. And then we'll go on to dissect out our artery. So we find our GDA and tie it off with a 2O silk. And then we'll open our pars plana, checking for any aberrant anatomy. We then find our splenic artery and dissect that back to the celiac. It's worth noting that if we do find any aberrant anatomy, that what we should consider doing, especially if it's on the rib, is maintaining the pancreatic head so that we can protect that artery at the repiced right. And then lastly, the portal vein. So typically what we'll do is divide the coronary vein early and dissect back to the splenic S of the confluence. Sometimes at this point, especially if the donor is becoming unstable or we've finished our dissection in other places, that some of the portal dissection can happen in the cold.
At this point, you've completed most of the dissection and you're going to be getting ready to flush and cross clamp and take out the organs. So you have a couple options for where you're in a cross clamp, and it kind of depends on if there is a thoracic team or not. If there is a thoracic team, it's a good idea to discuss plans for cross clamp and flush with them. And typically you would plan to gain supraceliac control of the aorta. I'd recommend doing this right before you're ready to start your flush, because this dissection can cause some bleeding, especially if you get into the lumbars. So you want to do it as late as possible. One method to do this is identifying the hiatus and using long allus to pull up and then Bovie straight down through the fibers. And then you can use your fingers to bluntly dissect around the aorta on either space to make sure there's room for the clamp. Another option is to just complete this dissection bluntly. It does cause a bit more bleeding that way, but if you're ready to flush and clamp, that's not a big deal. So you can just use your fingers, identify either side of the aorta with your middle finger and index finger, and feel down to the spine, then create that space around it bluntly. If you're going to cross clamp in the chest, you'll want to make a sternotomy for this if there's no chest team. Typically, I'll wait until after heparin is given and right before I'm ready to flush and cross clamp, since the sternum can bleed. You'd want to sneak a finger at the sternal notch and under the xiphoid to create some space here bluntly, and then insert the sternal saw. I typically start at the xiphoid and saw upwards towards the sternal notch, but you can saw downwards as well. Be aware of any sternal wires if they've had a prior sternotomy, and have a plan for opening them. Once the sternum is open, you can insert the finichetto, retract the sternum, opening up the chest and open the pericardium. You'll be able to palpate the descending thoracic aorta in the left side of the chest here.
Okay.
You have wires in your chest. What is your normal go-to?
If there's wires in the chest, I'll either try to open them up at the lower aspect of the incision prior to cross clamp, or open them up all the way. If you're doing a kidney-only case and you don't actually need to get into the chest to remove the liver, you can even just cross clamp supraceliac and then vent through the upper vena cava in the abdomen.
So I just avoid the wires entirely and go off center and have just a bunch of ribs that are just crossed. That's my go-to move.
Let's say during the case, while you're dissecting out the SMA, anesthesia pulls down the drapes and say they're struggling with some hypotension. What steps do you take when a donor becomes unstable?
So it's pretty simple. You just essentially pause the operation, and you can discuss with the cardiac teams kind of their situation and the stability with anesthesia. You have a discussion with the opio coordinator and take a quick look at the organs. And sometimes the operation needs to be sped up or slowed down based on how the donor is doing. So as Dr. Waugh and Dr. Dauch mentioned before, you have to be ready to be able to cross clamp. So just kind of look around and assess the situation.
I think from an abdominal perspective as well, you can consider things that you might be doing that are compromising stability, like flipping the liver itself. That tends to be something that we see quite often, even in the hepatectomy on the recipient side. Brain dead donors can be very unstable in the OR from time to time, so it's really just all about communication.
You return the liver to normal position and the vitals improve, but the donor remains hypotensive. After discussing with the chest teams, you decide it's time to proceed with cannulation. Walk us through the next steps.
The next steps are basically the critical point of the operation that need to be communicated with all the OR teams, the anesthesia, and the OPO staff. So prior to cannulation, it's generally standard practice to give the donor a big dose of heparin. Similar to plane taking off, this is the final check off between the pilots, and so the heparin should generally be given 3 minutes before cannulation or cross clamping in brain dead donors. It's also important to talk to the other teams to make sure they're also ready for heparin. In DCD donors, it's different. It's generally given approximately 3 minutes before they extubate the donor.
Heparin has been given. You spend the next couple of minutes completing liver mobilization and taking down the gallbladder. Anesthesia lets you know at the 3-minute mark. The chest teams both confirm it's okay to cannulate, but request you hold off on flush until they have their cross clamp on. Can you take us through cannulation?
Yeah, so you want to make sure that you have your aortic cannula sitting right next to your right hand, and make sure that it's been forward flushed with no air bubbles in the line before this process begins. You also want to make sure that you've got someone there ready to run the flush when the time comes. I'll then tie down the distal aorta with that number 2 tie that I've already placed there, right above the bifurcation. I'll then pinch the aorta just proximal to this with my left hand to occlude it, and then cut straight down on the aorta between my ties with my right hand. With my left finger still pinched, I bring the cannula into the aortotomy. I'll then ask my assistant to hold the cannula steady while I tie down the proximal tie, and I will hold their hand in the exact position I want them to keep it in while I'm doing this. I'll then tie the upper and lower silks together. If there's no chest team, it's okay to start the flush now. However, if there is a chest team, I'll check in to confirm with them when I can start my flush. We're trying to avoid the potassium-rich preservation solution from the abdominal flush from damaging the heart. Once it's time, either after you've started your flush, if you're an abdominal-only recovery, or after you've discussed cross-clamp timing with the chest team, you'll proceed with that. So if you're doing the supraceliac cross clamp, you can have your assistant gently pull the stomach down. Place your middle and pointer fingers of your left hand on either side of the aorta. If the flush is running, it'll feel cold, and you can slide the cross clamp over your fingers and push hard towards the spine. You'll actually end up sliding the clamp to the left of the spine and all the way to the back to make sure that you're on either side of the aorta. If there's no chest steam and you're cross-clamping in the chest, you can bluntly get around the aorta with your left hand, again, being able to feel it with the cold solution running through it, and make sure at this point to double-check that you don't have the esophagus in your hand. Oftentimes there'll be an NG tube in, and then you place the clamp with your right hand, sliding it again to the left of the spine all the way down towards the back to ensure it's completely clamped. Next, you have to vent the heart to ensure that there's adequate forward flow of the flush. You'll retract the heart cephalad and cut into the right atrium, and you can place a suction down the cava at this point. Next, you're going to fill the belly with slush, and don't forget to place slush around the kidneys as well in doing this.
You cannulate and cross-clamp without issue. You begin dissecting out the splenic artery. However, the OPO coordinator calls out the flush is no longer running well. Can you take us through troubleshooting the flush and what you're looking for to know that the flush is running well?
Yeah, sure. So the flush of the organs is really a crucial aspect of the procurement. So we typically flush with about 4 to 8 liters of preservation solution through the aorta, and if possible, another 2 liters through the portal system. So initially the small bowel should blanch and lighten uniformly. The liver should take on a homogeneous, almost light brown waxy color, and the effluent from the IVC that gradually become clearer and clearer. Now, if the OPO coordinator says the flush isn't running well, there's really 3 issues and areas that you can look at. The first is the cannula at the aortic bifurcation. It's not deep enough in the aorta, it may be too deep or abutting a posterior wall. The clamp you place around where the cannula is constricting it, the cell ties were placed too tightly, or the cannula is kinked. And usually taking a good hard look at the cannula can make your flush flow better. The second is the aortic cross clamp. If the chest team didn't fully cross clamp the aorta, if you didn't fully cross clamp the aorta above the liver, you lose forward pressure and the flush can slow way down. And so you make sure the clamp is completely across the aorta, not catching any diaphragm or crura or sitting crooked, and sometimes you just need to reposition it. And finally is the outflow obstruction. The solution cannot escape the abdomen and be sucked out through your suction. So the IVC isn't venting well, or the liver bowel are compressed by your retractor. The blue towel that you use is somehow limiting the escape of fluid. And so if you don't vent well, the organs get engorged and the flush stalls.
After manipulation, the flush is running better and you continue the dissection. You've completed 6 liters of aortic flush and 2 liters of portal flush, and the effluent is clear. Take us through the steps to completing the liver recovery.
The next thing we typically do is take down the left and right diaphragm. I normally take the right down all the way down to the spine and the left down to the esophagus. At that point, we look for our splenic artery and dissect that back to the celiac, and then move on to taking the duodenum off of the pancreatic head. At that point, what we can do is find the portal splenic confluence, and we'll cut that. The last thing we'll need to do in the abdomen is cut the vena cava, which will be very close to your right kidney. So we just need to make sure that we protect our left renal vein and our right renal vein whenever we're cutting across the cava. And then what we'll do is cut the aorta just below the SNA, avoiding the renals. So typically what I do is kind of snip into the aorta itself and then look for the renal orifices that will come either right at the level of the SNA, and if that's the case, you kind of bevel up your scissors to cut on an angle, or if the orifices of the renal arteries are further down, then you can just cut straight down on the aorta itself. After that, we go back up into the chest and cut the aorta, as well as the upper cava, just right at the level of the heart. To take it out, we normally put our index finger through the aorta and our middle finger through the cava, picking up the liver itself in one hand, and then our thumb actually will hold back our splenic artery, portal vein, and common bile duct just to protect them as we're cutting underneath along the spine.
Great. You safely complete the liver recovery. Can we walk through taking out the kidneys?
Sure. So once the liver is out of the body, I remove the aortic cross clamp and pull out the aortic calcaneus. The next important thing to do is identify the left renal vein, which crosses the aorta, and I cut it right as it enters the IVC. So once that's done, I take the curved man, I go right down the middle of the anterior aorta and split the aorta basically into 2 halves. Once I can see where the two renal arteries are from the inside, then I split the posterior aorta down the middle, and usually the lumbar arteries will guide you. So now you have two basically separate systems. So I first moved to the right kidney. I cut the distal IBC if it's not already cut, and I identify the ureter at its most distal point and cut it. Remember, the proximal IVC is already cut during the liver procurement. So with the assistant pulling the right kidney gently out of the body, holding the ureter up, I use a big Metz to safely cut the aorta, and I stay right on the spine, and the assistant generally pulls it out of the body until it's screaming past off. For the left kidney, we move to the left colon and dissect it free from the lateral wall. Again, we cut the distal ureter, and using a similar motion, I cut free from the aorta from the spine. Sometimes the kidney is still adhesed a little bit to the colon, and so we cut the kidney off the colon until it's safely free.
You have safely recovered the kidneys now as well. Can someone reiterate the division points of the different vasculature?
Sure. So the suprahepatic cava within the chest is divided above the right atrial appendage. This may happen in the chest by the chest team if they are present, but it should be done with both abdominal and thoracic surgeons in conjunction and in agreement about where that cut will take place. The infrahepatic cava is divided just above the left and right renal veins.
I mentioned here just that the right renal vein is very thin, so if you're pulling her out in this area, you can easily rip the right renal vein off.
For the aorta, we divide supraceliac above the celiac trunk and infrarenal just below the SMA, but above the renal arteries. The splenic artery is taken a few centimeters off the celiac. The GDA is tied at its origin and divided, and the portal vein is divided at the SMV splenic vein confluence.
Let's say you do have an aberrant right or left. How does this change the process of cutting out the liver?
For an aberrant or replaced right hepatic artery coming off the SMA, the key is to preserve the SMA in the pancreatic head arcade. That artery often runs right behind the portal vein and hugs the pancreatic head. So usually what we do is when we're taking the duodenum off, we'll actually keep the pancreatic head and divide just the neck there, protecting where the right hepatic artery is coming out of the SMA itself. It's important not to pull on this or strip it and divide anything in the pancreatic head itself, because you can always enter the right hepatic artery there. To preserve a left aberrant artery after mobilizing the left lobe of the liver, usually what we do is retract the stomach downwards and divide the pars placida about 2 or 3 centimeters beneath and above the left aberrant hepatic artery. After cross-clamp and flush, we dissect the lesser omentum close to the lesser curvature of the stomach wall together with the left gastric and left aberrant hepatic artery up to the diaphragm. I should also mention these are the two that most residents know about, but there's always a chance that the aberrant left hepatic is actually coming directly off the aorta, so you have to protect it there as well.
Can we talk a little bit about pancreas recovery and how it changes the operation and these division points?
Yeah, so if we're recovering the pancreas, then we need to ensure that there's adequate vasculature. So you want to divide the splenic artery near its takeoff from the celiac and send that with the pancreas, and divide the SMA near its takeoff from the aorta and send that with the pancreas as well. The portal vein is then divided just distal to the splenic SMV confluence to ensure that they have enough vein to go with the pancreas, and you send part of the duodenum as well and staple off the antrum and D4, and all of that gets sent with the graft.
I would like to add that in the cases where you actually have a replaced right hepatic artery, it's very difficult to recover the pancreas because the replaced right generally goes through the head of the pancreas. So if it's a young or healthy donor, these discussions need to be had between the center accepting the liver and the center accepting the pancreas.
Anything else you do before you unscrub?
Yeah, so you need to recover the iliac vessels in case they're needed to be utilized in the recipient surgery. They're crucial in pancreas and liver transplant. Maybe not so much in kidney, but once in a while we do need them. Once the kidneys are out, you have to do a quick anatomy report with the OPO coordinator, and I always check in with the scrubs to see if they need help with the quick closing.
IOU-BTK fans, it's Scott here with a word from our sponsors, and that's FIGS. And so it takes heart to build bodies that break records. Over the last 6 years, a team of incredible healthcare professionals did what most people thought was impossible. They rebuilt the body of legendary Olympian Lindsey Vonn after a series of devastating injuries that forced her into early retirement. Now she's headed to the 2026 Winter Games, ready to break records once again. This February in Milan, Lindsay's team and the entire USA medical team will be wearing FIGS. You can rock their official uniform too. The new Team USA collection from FIGS is engineered with FiberX, their most durable fabric yet. FiberX is setting the new gold standard for high-performance scrub wear. It's lightweight, breathable, and ultra-resilient, and of course, the styles come in red, white, and blue. Check out the limited Team USA collection and get a 15% off your first order at wearfigs.com. That's WEARFIGS.com with the code FIGSRX. That's wearfigs.com, code FIGSRX.
Let's move on to the next case where we'll be talking about DCD. Can someone highlight the trends in DCD in regards to abdominal organ transplantation?
Sure. So if you looked at proportions, the shift in the United States is quite marked. 10 years ago, only about 6% of the liver donors were DCD. Now it could be over 50%. Kidneys concomitantly have risen to also about 50%. However, have been a steady, predictable growth. But the liver DCD transplantation in the United States has absolutely exploded, basically due to the rise of liver pumps, which makes these allografts very highly recoverable and increases the utilization rate and outcomes.
So DCD organ recovery is becoming routine for those in the transplant world. That takes us into case 2. You're told about a 45-year-old woman with a devastating anoxic brain injury after prolonged out-of-hospital arrest. She does not meet brain death criteria, but her neurologic prognosis is considered poor, and after multiple family meetings, the family chooses comfort measures and consents to DCD liver and kidney donation. There's no heart team involved. She's at a medium-sized community hospital. They do some cardiac and general surgery cases, but they have limited experience with donation after circulatory death. Your center accepts the grafts, and transportation is arranged to the donor hospital. Can you walk us through how the preoperative planning and timeout differ between DCD and brain-dead donors? What do we have to plan for before the operation starts, and how does it change the choreography in the OR?
Sure. So the preoperative planning in a brain-dead donor versus a DCD donor is markedly different, and it can change the whole rhythm of the case. So for a brain-dead donor, generally proceeds as a straightforward 2 to 3 day course, and the timeout is pretty routine. The donor is already declared dead by the neurologic criteria. They're still being ventilated. For a DCD donor, it's much different. I mean, it's a little more of a fire drill. So the timeout becomes a timeline meeting. We have to walk through everything that happens, where withdrawal will happen, whether it be in the OR in the recovery room. Some DCD donors are withdrawn in the PACU, what time heparin is given. A member of the hospital who's not part of the transplant team has to declare death. They have to confirm circulatory arrest. There is a 5-minute no-touch period after death is declared on the monitor. In this, physician or nurse also listens to the patient's chest with a stethoscope to confirm there's no cardiac activity. And then in the OR, who is documenting the blood pressure, who's documenting the oxygenation saturations and things like that. So it's much more choreography and mechanics. In a brain-dead donor, you're timing your cross-lamp with the other teams. And in the DCD case, you're kind of timing everything from withdrawal to arrest to incision to cannulation.
We've covered a lot already, but let's highlight the differences between DCD and OR preparation and the surgical steps. So Dr. Waugh, is there anything different with your back table for a DCD donor?
Yeah, so the time to get that aortic cannula and start the flush and cross clamp is crucial, and I want to be able to do it as fast as possible. So I make sure they have a separate Mayo stand set up with just the bare essentials of what I need, nothing additional that might get in the way. So I make sure to have 4 penetrating towel clamps, a 10 blade, Mayo and Metz scissors, 2 Gokers, 2 Babcocks, the sternal saw set up how I want it with the blade facing up and making sure that it works, the finished shadow set up correctly, a long peon or aortic clamp, some hemostats, a couple short DeBakey's, and a non-penetrating towel clamp. Sometimes they'll set up with extra right angles, ties, things like that, and I tell them to remove all of that, so it's just the bare essentials.
You complete the pre-OR huddle and scrub in while the scrub nurses prep and drape the patient. The donor family is brought into the operating room, heparin is given, and then 3 minutes later, life-sustaining measures are withdrawn. The ICU delivers appropriate end-of-life medications for pain and anxiety. The donor passes with functional warm ischemia time of 12 minutes. The ICU declares death. The family is escorted out of the OR by the OPO and your team enters. The 5-minute no-touch period passes, and the ICU verifies death again. You are told you can begin the surgery. What is the differences in the order of steps that take place for abdominal organ recovery?
What we normally do is make a cruciate incision like we do in the brain dead donors and the cannulation, but then right after that, what we'll do is clamp the iliacs and cannulate the aorta right away. If the chest team is not a part of the procurement, then we open the chest ourselves and cross-clamp the aorta immediately thereafter and vent our right heart. We then place ice throughout the entire abdominal cavity, making sure it's around the liver as well as the kidneys, and then we go ahead and flush the gallbladder, take down our diaphragm, finish our cannulation, identify our SMA, the left renal vein and right renal vein, dissect our common bile duct, GDA, and flush the bile duct, find the splenic artery, and then separate the stomach from the gastrohepatic ligament and open the diaphragm to the esophagus, pretty much getting ready the liver to be able to deliver the body.
So the basic steps are the same.
The important part in the donation after cardiac death is really time because of the functional warm ischemic time, and what you need to do is get the liver and the kidneys out of the body as fast as possible. So as soon as you finish the cannulation, what we typically do is clamp our iliacs with cokers, and then instead of getting around the aorta with a right angle clamp, what we do is actually pinch it between our fingers, or you kind of push it down against the spine itself and actually clip into it. So you'll have blood coming out of that space, and then we'll throw our cannula in and hold it in place with a Babcock or two, depending on really the integrity of the aorta, because sometimes it's quite calcified, so sometimes requiring 2 Babcocks. I think it's worth noting, especially whenever you're setting up the back kibble, that we don't use Bovie, cautery, and DCD donors. This is all colds, and so basically it's meds and pickups. That's pretty much what you use. We'll always have 3 suctions up ready to help with getting the flush out of the abdominal cavity so that we can see better. I think it's worth noting too that you're not going to be able to look for your aberrant anatomy, so we always just assume that it's there and make our dissection very safe and close to the stomach for the replaced left, and then we actually take the pancreatic head to make sure we protect any replaced right and hepatic artery as well coming out the SMA.
You only need 1 minute to talk to your assistant prior to a DCD abdominal recovery. What advice would you give them, or what would be the most important roles that they can play?
Well, typically I like to run through the whole operation with them, but if I had just a minute or a few seconds to tell them how they can best help me, it would be with the initial incision and cannulation, because I want to be able to do this, like I said, as fast as possible. So once we're in the abdomen, I tell them to hold up on the cecum and hold back the small bowel so that I can enter the retroperitoneum below the cecum. And I just bluntly spread here, basically just using my fingers to be able to identify the aorta and its bifurcation. So it's very important for them to be able to give me the proper exposure to do that. I also emphasize how important it is for them to suction while I'm working, because the ice will start melting as you divide some smaller veins. You'll get the flush running into your field as well, and you can end up operating underwater pretty quickly.
I mean, I agree completely with Evelyn. The only other thing that I always did when I had an assistant was just tell them to keep pulling harder, because I feel whenever you're operating as a resident, and you want to be very gentle with what you're picking up and moving around, but this is a procurement surgery, so when we're asking them to move the small bowel or the colon around, or even the stomach itself, I always want them to pull harder than they anticipate pulling. That gives us a better view of where we're working and what we're dissecting out, and keeps it safer for our recipients and the organs that we're recovering.
Timing is so important in these cases. So can someone highlight gold standard times of what you guys are aiming to recover these organs in?
For brain dead donors, warm ischemia really starts at the cross clamp, and most centers aim for liver out within about 20 minutes, faster if the donor is unstable. For donation after cardiac death donors, ASTS recommends liver out within 30 minutes and kidneys out within 60 minutes. And practically speaking, in DCD cases, we often aim for skin incision to aortic cannulation in about 2 to 3 minutes, and we want the preservation flush running almost immediately after cannula placement. Venting should happen right away, within seconds, really, to avoid any venous congestion. These timelines aren't arbitrary. They directly affect delayed graft function in kidneys and ischemic cholangiopathy in livers. So when you hear your attending pushing for efficiency, it's because the clock really does matter in transplant surgery.
These cases can be overwhelming, and that's normal. They're fast, they're crowded, and they can feel like a lot, but they're also an honor to participate in. A donor and family has made an extraordinary decision, and we're responsible for carrying that forward. I think it always helps to follow the organs into the recipient OR when you can, because it really reminds us of why this all matters. So we can close with some high-year clinical pearls. What do you hope your learners take away?
I think one of the most important things to take away from a procurement surgery is this is the best opportunity, especially as a resident, you will ever receive to really learning anatomy. You have the opportunity to go and participate in a procurement, especially as a resident or a med student. I would take it every single time.
I think my takeaway from going through learning how to do the procurement operation is you should go in with the attitude owning this surgery and making it your own. This is your opportunity to truly become an independent surgeon. You're going to learn quickly, and you're going to learn by making mistakes, and you're going to learn from your success as well.
Yeah, I think just to Dr. Dauch and Dr. Waugh said, is it's an extraordinary operation to be able to see stuff in the human body you can't see in any operation if the patient survives. But finally, to think about this, the generous gift, as you mentioned, these are people that lived full and meaningful lives, and they're actually heroes for donating their organs, and it's just a wonderful responsibility that we give to be able to save other people's lives for this gift. And
a huge thank you to Dr. Waugh, Dr. Dauch, and Dr. Maskin for this masterclass, and of course to the donor families whose generosity makes transplant possible. This has been Behind the Knife. We hope this deep dive gives you the big picture understanding and technical framework you need for your next procurement. We'll see you next time.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.